All right.
All right. Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of Northeast studio in Fall River, Massachusetts. Today we'll be discussing vascular disease in women with Dr. Garima, excuse me. Let me start that over again, because I already messed up your name.
That's all right.
Sorry. All right. Hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast studio in Fall River, Massachusetts. Today we'll be discussing vascular disease in women with Dr. Garima Dosi. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit Bay Coast Bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are greatly appreciated. Well, thank you so much for being part of our show today. We greatly appreciate it.
Yes, I would also like to thank you for giving me this opportunity. This is my first time on the podcast, so
That's great. I'm sure that you'll enjoy
privileged.
it.
Thank you.
Oh no, we appreciate it, and I think there's a lot that our audience will learn today. And I want to start off just basically, maybe you can just tell us a little about your background. I think that'll be important just to frame the conversation.
Yes, so I'm a board-certified vascular surgeon. I've been in practice for about 10 years now, and I recently joined the Primacare group. So yes, so different.
Nice.
Where did you go to school? Where was your education?
So my earlier education is all from India.
Mm-hmm.
My medical school is from Mumbai, Topiwala National Medical College. And then I came to US and I did my residency and fellowship. So residency is from New Jersey, fellowship is from University of Maryland in Baltimore.
Great.
Nice.
And then I landed in Boston, Massachusetts, Rhode Island area.
So before coming to Primacare, were you practicing in Boston, the Boston area?
Yes, so I was practicing at as a part of Brigham and Women's Hospital. And,
Great hospital system.
Yes, yes.
That's
Well,
excellent.
I'm glad that you came down here because we definitely need you.
We have a lot of vascular disease down here, I'm sure, as you've already determined.
Yes.
A lot of cardiovascular disease in general, so
Yes.
a lot of it probably based on high risk of diabetes or incidence of diabetes, maybe some genetic factors.
Yes. So actually, when patients come to me, they ask like, "Why me?" Right? This
Yeah.
question, like, "Why me?" So I ask them some simple few questions. I'm like, "Do you have high blood pressure?
Right.
Do you have diabetes? Did you smoke? Did you ever smoke?" Right? They say, "No, we quit them, but did smoke though in the past? Do you have high cholesterol? Do you have any family history? Your parents, your siblings who have an early onset of any cardiovascular disease puts you at risk." And then definitely age and
Yeah, of course.
gender puts you at risk. So these are like the basic risk factors, and majority of the patients are like, yes, 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 to have all of these boxes.
Yeah, a lot of the patients I see have every risk factor on that
Correct.
list.
Yes.
And it's not uncommon to see that. They
Correct.
smoke, they have diabetes, they have hypertension, high
Right.
cholesterol, et cetera, and family history sometimes too.
Correct.
So
Yes.
what does a vascular surgeon do? Tell our audience a little bit about that.
Before we get
Oh, yeah.
into that, can I just back up and ask you to describe what vascular disease is
Okay.
for people that are listening and may not know?
Yeah, so vascular diseases are, it's a very broad spectrum. I would say, we deal with both arteries and veins.
Okay.
Right? So there is a vascular disease, could be an arterial disease. And I describe to patients, think about arteries are pipes that are coming out from the heart that is
Right.
taking blood to the organs.
Of course.
And veins, think about as pipes which are taking the blood from the organs or periphery back to the heart for circulation.
Okay.
So there could be problem in both. And depending upon which part of the body that is affected, we can help.
So now, when you talk about diseases in the general sense, narrow it down for us now, like what are the types of diseases that you're seeing most frequently and treating?
Yes. So most frequently, so for the arterial side, what we see is narrowing and blockages in the circulation in the legs,
Yeah.
which is called peripheral arterial disease, which can patients usually present with pain with walking,
Okay.
or have sometimes it is a little more advanced in the form that they have wounds, ulcers, or toes that have turned black and are not healing.
Okay.
Gangrene, basically, yeah.
Gangrene. So this is peripheral arterial disease, which is the most common. Then the second most common is a carotid artery disease, which is the carotid arteries are two big blood vessels in the neck that supply blood to the brain, and they could have had narrowing, same risk factors, which can lead to stroke or a stroke-like event, and so that's carotid artery disease. Aneurysms, which is could be, so aorta is a big pipe coming out of the heart, which could get affected and can have aneurysm. And depending upon where that aneurysm is, it is in the thoracic aorta, which is in the chest, or aorta, which is in the belly, which is called abdominal aorta, could have aneurysms, and we deal with
It's
aneurysms.
just an enlargement of the vessel, just so our audience knows.
Right,
But
it's like ballooning
but
of the blood.
Ballooning,
Right,
but
yeah.
there's a major issue that occurs when that happens. and-
Correct, because the wall becomes weak. Think about it as a pipe, but it has a balloon in the middle, and because of the blood pressure, it keeps weakening the wall, and it can rupture,
Right,
which
right.
could be fatal.
Sure, I mean, there's a lot of blood going through that vessel,
Correct.
so
Correct.
once
And-
that ruptures, if it's a complete rupture, it doesn't take long to,
Correct. It's mortal.
pretty dramatic, right?
Pretty dramatic.
Yeah.
Correct. Yes. So aneurysms. Then other than that, if you see on the venous side of the disease is venous insufficiency, which is called when the valves inside the veins are become leaky. They can go to leg swelling. You see, which could be a spectrum of disease starting from just simple spider veins, which could be just cosmesis, versus lot of leg swellings, pigmentation on the legs, legs leaking fluid,
Yeah.
resulting in ulcers called as venous ulcers.
Yeah.
So this is the venous spectrum of the disease. So these would be the common, but definitely there are many zebras
Right,
in
right.
vascular surgery
And that can be
too.
very hard to treat, those ulcers.
Venous ulcers are hard to treat, and also has a associated patient quality of life.
Yes.
Going to
Definitely.
wound recovery centers, pain, taking care of these wounds.
Right. So you're pretty much dealing with almost every blood vessel in the body, whether it be arterial or venous, as a vascular doctor, except those in the heart per se and in the brain, I would think.
Yes, that would say.
And that's basically, but everything else is fair game for a vascular surgeon.
Yes, it is.
Okay,
Yes,
interesting.
it is. Yes, it's
So now, when we're talking, like you had mentioned that gender falls into the family of risk factors, and like why are women why are we more of a risk to develop this?
I don't know.
than
Are women
men?
more of a risk than men?
so. Women are protected actually
Okay.
till they reach menopause. They are protected from the cardiac risk, from all
Yeah.
these risk factors. So you generally do not see younger women with a peripheral arterial disease unless the risk factors are so out of control, like
Yeah, of course.
which is, but on because the estrogen is a protective effect.
Yes.
Okay.
But once they reach menopause, then the effect of estrogen is gone.
It's a whole new game.
It's a whole new game, and that's when hormone replacement therapy comes into picture. And I think we had a pretty good podcast with Dr. Lakshman
Yeah.
explaining about
Yeah.
it. And so women do catch up to men, I would say, by the age of 60 in terms of similar risk factors in terms of arterial diseases. So till that time, the protective effect of estrogen in the early years protects them.
Yeah, we had a really interesting podcast with Dr. Lakshman because, he talked quite a bit about how estrogen replacement therapy was really quite beneficial. Although many people out there in the general audience, I think, still think that it's a bad thing because of data that was out many years ago with the Women's Health Study,
Right.
which has been
Screwed.
which has been refuted since that time. But
Correct.
interestingly, there's a lot of women who suffer through
Right.
menopause and postmenopausally, and who would benefit from hormone replacement.
True.
Here's one area where they
Very
would benefit.
good area, yes. And usually we just limit the hormone replacement therapy to saying, do you have hot flashes and things like that, right? But
Yes, exactly.
some women, I know women in my family who are not on hormone replacement
Right.
therapy because they're like, no, that's something normal. We'll just deal with
It's
it.
part of life. It's
part of
normal. It's the
life.
way things should
I
be. Or
don't want to be on
right.
meds and
Exactly.
things like that.
And,
So-
Exactly.
and there's still that misinformation out there about,
Cancer.
deleterious effects,
Yes.
which, as mentioned, has been pretty much refuted.
Absolutely.
Excuse me.
Right, right.
So now, when you see men and women, do women present a little differently?
So women, by nature, the blood vessels are smaller in size
Okay.
as
Okay.
comparison to
Of course.
men.
Mm-hmm.
And somehow the disease is a little more advanced in
Okay.
a smaller blood vessel. Definitely does pose procedural or from a surgical standpoint a little
Mhm.
bit challenging to treat them rather than male patients.
Of course.
And for sure, sometimes they do not come up to seek help right away, right? Just like, oh, it's my back pain. Oh, I may have done some few things
Yeah,
all
yeah.
together, and it's one of those days I was multitasking.
Right.
Yeah.
And it will go away. I'll just take over-the-counter meds. It will go away. So they ignore their symptoms for a longer time, in my opinion. I
Yeah.
do not. That's what I have. That okay, this has been going on for years, right?
Exactly.
And they come to when it gets picked up by somebody in primary care, or when they go to a specialist for back pain and they pick up, oh, you do not have a palpable pulse. It's not coming, your pain is not your back pain. It's some more vascular in nature. So that's how they get picked up, because it's just, you don't go to the doctors to
Yeah.
for these
exactly.
pains, which
Like, what's and I know this is like a big old general broad stroke question, but like, what's the break point? So like, if I'm at home and I'm like, oh, this is bothering me, like I might go like a week or two, like, oh, it will go away, or I'll get
Sure.
used to it, or I'll figure out how to manage it. Like, at what point should I not be doing that?
So I always think, that's what I tell to my family and friends, that if you think that, okay, you were doing something and you pulled a muscle and it should get better in time.
Yeah.
If it's not getting better, it's persistent,
Right.
it's time,
Or progressing.
then you should seek,
Yeah.
ask for help.
The other day, I wanted to show this to you too, Chris. The other day I got in the mail this solicitation. Come and get your whole body scanned, and we'll look at everything.
They do vascular screening.
Yes,
and
but it's like a imaging too.
Yeah, yeah.
Is that like worth it? I mean, it was maybe $100 or something. Like, do I
I'll give you my
find?
opinion, but I'd like to hear your opinion on
Yeah.
that. 'Cause I actually have a really interesting thought on that, but go ahead.
So yes and no. It's a very generalized, broad screening.
Yeah.
For sure, those patients who do not have risk factors or have very well controlled risk factors, right? There are a lot of patients who have high blood pressure, who have diabetes, who have high cholesterol, but their risk factors are very well controlled with meds. They eat healthy, they exercise, they're pretty active, have no symptoms. Then even if we find something, are we going to do anything about it, right? So that's one. So
You might find mild disease.
you might find mild disease, sure, but it's just going to make them more nervous. But
Right.
that being said, if you are up to date with your primary care physician, with your,
We're good.
we are good, right? Because that's what I would say,
Yeah.
that if you're up to date with your primary care, with your OB, then you are
No,
good.
it kind of plays on your fear a little bit,
Yeah, it's interesting. 'Cause as a primary care doc, I've had a lot of patients go for these tests.
Yeah, yeah.
And usually they don't ask me about it beforehand. They just go, and sometimes they will ask me. And if they're having symptoms, obviously they shouldn't be going for this screening. They can go for a regular test.
Of course.
But there are patients I've had have this done who they've picked up things that have led to, secondary testing. That's
Ah.
been significant. So it's interesting. But most of the time, you're right. I mean, generally, you're going to probably have picked up some of this stuff already, but I'm not adverse to the testing.
Yeah, I'm not adverse to it, but I also would also say that take it with a grain of salt.
Yeah. I mean, they do it's a lot for, a reasonable amount of money, but some of this stuff might also just be covered by your insurance. Like, if you have symptoms, don't have this done. Just go to your doctor and.
Correct. Definitely.
If you want to have this symptomatic screening and spend $150, because usually it's hard to get screening done and covered by insurance unless there has to be a reason.
Right.
You can't just go order carotid ultrasounds on everyone.
Exactly.
And
Right.
all these other tests. So.
But sometimes, I mean, quite frankly, I worry about that a little bit because I fall into some of these risk
Right,
factors. My
right.
mom died of a stroke, so I'm like, I wonder what my carotids are doing right now,
Right,
because
right.
it's kind of like, oh, I'd want to know.
Yeah, so, maybe it's a reasonable thing for someone like yourself.
Yeah, because I think if I went into my primary and just said, well, if I'm not having any signs or symptoms or anything, you might not do anything.
Well, I mean, if you came to me and you didn't have any symptoms and I didn't hear anything, and it'd be hard for me to get that covered by
Yeah.
insurance.
Right.
That'd be the reality of it.
Yeah.
So,
Yeah.
So can we go back to a little bit talking about my bad lifestyle and risk factors and stuff? Like when you're I'll just talk me personally, but you're in your 20s, your 30s, you're not thinking about too much of this stuff. When I grew up, there wasn't the big awareness that is certainly out there now, or I wasn't aware of it. But now that aging a little bit, I'm like, oh, I want to turn some of this stuff around. Like, what's that? Like, how many of these things can you turn around?
So,
Like, when is it too late? And just like, you know what, buddy?
well, if it's too late is when you have had like symptoms, like if you had a stroke,
Yeah.
or leg is gone that far with the narrowing and blockages that you ended with an amputation.
Yeah.
Right. So those are the things which are gone too far. But at the same time, if you have an intervention for any of these things, right, we want to make sure that that intervention lasts for your life.
Yeah.
You don't want to keep going and getting re-intervened.
Exactly.
So risk factor modification not only works to prevent progression of disease at time A, but also helps to make sure whatever intervention you had
Yeah.
stays patent
Yeah.
for the rest of your life. So any time point, risk factor modification is
Worth it.
worth it. Absolutely worth it.
All right.
Right.
No more Twinkies.
and what do you tell patients to do as far as risk factor modification? What should they be doing?
So yes, a good control. So basically, a heart-healthy diet, exercise, and if they have any high blood pressure, diabetes, high cholesterol, get those under control with medications if required, and quit smoking.
Yeah, basically the same that we recommend for heart health. It's the same system pretty much, right?
It's pretty much the same system.
Yeah.
Yes.
So,
Yeah. Quit
okay.
smoking. Yeah.
What's the biggest risk factor, do you think?
I think smoking.
I think so too.
Smoking.
That's the one that really seems
Yes.
to be the most notable.
Yes. It was
Can
smoking.
you guys just give a little nutshell explanation of what smoking does and why it's so bad?
So it's the what do you call it? Causes narrowing of the blood vessels, right? Because of the vasoconstrictive effect, and then also causes more progressive plaque formation.
Yeah, the toxins and whatnot. Yeah, it's amazing when you look at someone who's smoked and you look at their arterial system and their, whether it be coronary system or vascular system elsewhere, they can have incredible amount of atherosclerosis that someone who doesn't smoke may not have. And then if you put diabetes and smoking together, that's
Yes.
like the
Just
worst.
multiplies.
Increases the risk
Yeah.
dramatically of
Yes.
cardiovascular disease. And most of those patients already have hypertension too.
Right.
And many will have high cholesterol. Some of them
Right.
have every risk factor.
Yeah.
Yeah.
Especially in this area, I would imagine.
Yes.
Yeah.
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 We
Unfortunately.
still have a lot of people who smoke, which always amazes me.
Yeah, me too.
It really
exactly.
does.
There's
Yeah.
such like a stigma that goes along with it now, even.
We have a lot of. I still have some patients that it's a terrible addiction. They've tried and they
It's
can't.
expensive too.
It's expensive. Yes.
It is. It
Yes,
is. But there's still a
actually.
lot of smokers out
They
there.
said it's easier for them to get rid of alcohol and drugs than smoking.
Yeah, I used to actually teach a non-smoking course, if you will, in the elementary schools. We used to go out when I used to work at the hospital. We were hospital based as a respiratory unit. Me and some of my nurses would go out and teach like the little kids about like smoking cessation.
Right.
And some of the stats you saw, and now this was going back about 10 years, but some of the stats you saw, nicotine is the addiction that's the toughest to quit.
Yes.
And it takes like on average 7 to 8 times to be successful in stopping.
Right.
You know, so it's definitely an uphill battle, and
It's
kudos
a
to
tough one.
people
I mean,
that can.
I'm sure that quitting alcohol or drugs is no joy either, but nicotine is a tough one. It
Yeah,
definitely
you need
is.
motivation. You need good motivation. for
Yes,
sure.
yes. And usually when they come to specialists, when they have these end organ damages and they
Yeah.
come,
I'm scared.
they're scared.
Yeah.
They're scared. So,
So now you had talked about a couple of issues that you see, the peripheral artery disease, the carotid arteries, and the aneurysms. Can you kind of talk about diagnostics and treatment with each of those?
yes. So for peripheral arterial disease, depending upon what stage the patient comes to us, it's very quick ultrasounds that can be done in the office settings that can give us an estimate about how the circulation looks. Both, it's good for carotid arteries, the ultrasound of the neck, legs. You can look at the arteries with an ultrasound. It's an office-based test. They don't need to be NPO, or don't need to be, hold medications or not to eat or anything. It's just get
One
the
of those
ultrasound.
easy tests.
Easy testing. No poking or, blood
nice,
draws or nothing.
non-invasive
Correct.
test.
Yeah.
Same thing, ultrasound of the abdomen can be done. That
Okay.
that can look at the aorta, which is the blood vessel that gets affected by the aneurysm, and can get a fair idea with these simple tests as to what the problem is, or if there is a problem.
So now treatment for that, like let's just talk about like with the legs, like what are you doing to help treat that?
You talking about like medications or more interventions?
Everything.
Okay.
Yeah. So first is risk factor modification, as blood pressure, diabetes, quit smoking, high cholesterol, baby aspirin, 81 milligrams. Majority of the patients get on them, which is if you have a diagnosis of any systemic atherosclerosis, right? Aspirin is preventative.
I'm going to put a little asterisk after that because so many people these days are getting gastric bypass surgery and they cannot take aspirin or any aspirin products. So with the influx with people, or maybe you haven't, because you're probably dealing, I'm going to be biased for a minute, with more of the older population.
That's
so
true.
you might not have seen like this, like
Younger.
you might not have hit that where you're starting to see all these patients. But it seems like every other person has had gastric bypass
Or if they
surgery.
have GI bleed for
Yeah,
some reason or another,
yeah.
then it becomes a little bit challenging. But majority of the patients do
Can go on the
tolerate
aspirin therapy.
Usually they'll tolerate
enteric-coated-
81 milligrams
Yeah.
baby aspirin.
Baby
yeah.
aspirin, they tolerate pretty well. It's when you start going to other antiplatelets and
Yeah.
stronger blood thinners, then you have
Full
to
dose aspirin, Plavix, Coumadin, the like.
Coumadin or this new medication like Eliquis and
Right,
Xarelto. Then those becomes a little bit of
You know what I found is a real problem in primary care is, a couple years ago there was a lot of talk in the media about how aspirin did not help for primary prevention of cardiovascular disease in most patients, right? So I have all these patients who have heart disease and vascular disease who just stop their aspirin.
right.
And it drives me mad. I'm still picking them up here and there. They'll come in, why are you on your aspirin anymore? I saw something on TV that I shouldn't be on aspirin because it doesn't help.
Yeah.
It's interesting. I don't know if you may not see that because I see it more in
is-
primary
no.
care, but
Correct.
so many people stop their aspirin and put themselves in danger.
Yeah, no. I always tell this: if you do not have, and you're just getting picked up
Yeah.
as hey, I have these risk factors, but
Yeah.
we don't see any interventions done or anything, then I say okay, you can swing.
Right. If they don't have vascular disease
Correct.
or cardiovascular disease, because it's really just one system, we should probably just say that, right?
Right.
Then, okay, they don't probably need to be on aspirin, but these patients who have defined issues
Right.
shouldn't stop their meds.
No, absolutely not. Have coronary stents or
Right,
coronary bypass graftings, leg intervention, leg stents, carotid procedures done.
Right.
I usually would say no, aspirin is
course.
must.
But you
Yes.
brought up an interesting thing before. You were talking about end organ damage, and I think that's what some patients don't understand. They think about the person with the gangrenous toe or foot, but they don't realize that this can cause kidney disease, stroke.
Right.
A lot of other organs are affected also.
That's true. That's true. So, with smoking, we usually always think about cancer, right?
Right.
So some of the patients come to me and say, "Oh, I don't have cancer. Why should I quit smoking?"
Right.
Right.
Right. I'm like, no, but cancer yes, smoking can cause cancer and will cause cancer. And cancer can happen not just the lung, it could be just, head and neck, throat cancers too, but bladder cancer from
Sure.
smoking. But what we are missing is a bigger picture is these plaque that forms in the heart and the blood vessels there's no way to pick that up, right? With bladder cancer, you'll have some blood in the urine.
Right.
With lung cancer, you may have blood in the sputum. You may have
Right.
some way you get picked up. But all these other things, it's so hard to pick up unless you have end organ damage, which is like,
Right.
oh, my toes are turning black.
Yeah.
Right now,
and
the
by that
ball
point, it's advanced.
it's advanced too far, or you have a stroke or a stroke-like event, right?
Right.
It's kind of like a car that you don't get oil changes on. It's just like, you don't see a lot of the symptoms till your car just stops and dies and has a big problem, It's like builds
That's
up all the
true.
gunk.
Well, no, that's true. A lot of times, people wait too long.
Too long.
Yeah.
Yeah, because you may not have symptoms until it's fairly advanced.
It's fairly advanced.
Especially people who are inactive. I mean, if they're not walking a lot, they're not going to
They
get
won't.
claudication or
Correct.
pain in
They
their
won't
legs.
feel it. Right.
If they're sitting down most of the day, they're not going to feel it until it's really bad.
What do you do with a lot of your elderly population, though, that may be limited in their functionality? Like, obviously they can stop smoking or eat a little bit better, but what other things what kind of discussions have you had with that type of population?
So need to know how functional that patient is, right? Before we
Yeah.
start saying that you need an intervention.
Right.
Peripheral arterial disease has its spectrum
Yeah.
of symptoms and treatment, and one is do nothing.
Yeah.
Right? And those patients who do not walk and are not experiencing any symptoms, just because they have a disease doesn't mean it needs to be treated.
Right.
Sure, now the patient who does not walk but now has one of the toes is black in color or has a wound which is not healing, now that becomes like a quality of life.
Exactly.
They have pain in that toe.
Yep.
They have to have been on antibiotics, or the toe may need to get amputated. So
Right.
that now becomes a little more quality of life and maybe towards the point that we need a limb salvage
Yep.
kind of a situation. So
Yep.
yes, in that case, intervention may be needed. So it all comes to how functional the patient is. So it more comes to talking to the patient, like, what do you do? There's a similar patient who may be a postman. Now he walks and walks and walks all day. His job is now cannot do his
Right.
job
Right.
because he cannot walk. So that becomes a completely different.
My feeling is you have a lot of conversations and you're doing a lot of education with
Yeah.
people because this was probably, and in some instances, the furthest thing from their mind. And then all of a sudden they have this problem that they don't really know a lot about because it's
Right.
not like out there in the media really all the time, like some other diseases are or something, and they're like, what's going on? What do I have to do? What are you going to do? That's a lot of talking.
Like they talk more about, so I give them the same correlation, same example as like if you have blockages in your heart.
Yeah.
Think about blockages in the leg. So I give them, like, you can treat them with stents and balloons.
Right.
You may need like a heart bypass surgery. Same thing can be done for the legs. Just so that they can understand what
Right.
what it means.
Once they understand it's all the same big system, it
Right.
probably makes more sense.
Right.
Right.
So.
And that's an interesting question that comes up a lot. If someone's diagnosed with, say, coronary artery disease, they should be screened for peripheral arterial disease and vice versa, correct?
Yes, and usually these patients have some form of
Right.
peripheral arterial and carotid disease.
Right.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
What, can you talk a little bit about leg stents? Do you do a lot of those?
We do, yes. They're like stents, but balloon angioplasty and stenting of the arteries of the leg, yes. So if it's a minimally invasive procedure, can be done in an office setting. Not every patient needs it.
Doesn't sound minimally invasive. Like, I'd be like, okay, what are you doing to me?
Right. So it's as so yes, it can be done through a needle hole or a puncture in the groin with a small needle. We can do the balloons and stents. Technology has improved
Yeah.
way much than what I was in training to do this
Right.
procedure in an office-based setting. So yes, it can be very safely done in an office-based. Patient goes home the same day, ambulatory. So
And if they have good risk factor modification, if they stop smoking and they lower their cholesterol and they exercise and they do all the things we want them to do, how long do these stents last for?
they can last their lifetime.
And if they don't do those things,
Then, yeah, there are patients who have had their stents clotted off, same week or same month,
Same week.
same month, or very quick
Yeah.
that you would not anticipate and needs
Yeah.
more procedures.
Yeah.
But if there's good risk factor modification, good patient selection, these procedures do last.
yeah.
So what are you doing with the carotid artery? You had mentioned that too. Like, what are some of the things you do to fix someone up there?
Yes, so carotid arteries.
We're talking about these big arteries in your
Yes,
neck.
big arteries in the neck. So initially, the gold standard was an open carotid surgery, where you make an incision on the neck, open up the blood vessel, clean it out, and put a patch or sew the artery together, which is called as carotid endarterectomy.
Yeah.
But now, as the data has come, that carotid stents are also fare very equal to the carotid endarterectomy procedures. And stents patency is pretty good. And so carotid artery stenting is coming up. It's kind of like a minimally invasive procedure for a carotid.
And they'll last also a while.
They will last also pretty long, yeah.
Yeah.
There's a 10-year data already out for carotid stents that they last.
Now,
That's great.
correct me on this, both of you.
We will.
But I'm sure you will. I'm sure you will. But it was my understanding when I worked years ago in the hospital that you had to have a pretty high percentage of blockage to have the carotid endarterectomy, but maybe not so much now with stents.
No, so the indications remain the same
Okay.
for intervention. It's
Okay.
like the way you want to intervene, whether you want to
Okay.
do a carotid endarterectomy or you want to do a carotid stent. So indications remains the same.
Now, what's like moderate blockage compared to like, oh, we better do something today?
Right. So so again, the screening is done by ultrasound.
Okay.
Carotid ultrasound. That can give us a pretty good idea about a carotid artery, whether it's open or closed, and how much is the degree of plaque in the circulation. Carotids which are asymptomatic, that means the patient has not ever had a stroke or a stroke-like event because of that carotid artery, greater than 70%,
Okay.
or is the thing, or
Like when you would stent?
would
it's
withstand
like,
or intervene.
okay.
Okay. Patients who are symptomatic, then it comes to whether that carotid artery was the reason that the plaque ruptured and gave the stroke or a
Okay.
stroke-like event, or was it something else that gave the stroke? Then comes the question of,
So when you're saying a stroke-like event, is that when people say, oh, I had like a little mini stroke?
Yeah, like a TIA.
Yeah, like
TIA,
yeah,
correct.
yeah, because you always hear
Transient
people
ischemic event.
like, I had a little mini stroke the other day, and you're like, oh,
I had a stroke, but did not had a stroke.
yeah,
Yes.
yeah. Oh, but it
They were
cleared up.
lucky,
I'm
and
fine
they were
now.
lucky, and it reversed.
That occurred, yes.
Yes,
Yeah.
yes.
It's a transient ischemic attack.
Yes.
Yeah.
TIA.
All right.
Yeah, but those TIAs can be dangerous, because
Sure.
there's just
Absolutely.
ticking
It's a
bomb.
warning sign.
Yeah, yeah,
Sometimes you have patients who they'll have sudden loss of vision
yeah.
because they'll have a small little tiny bit of plaque that goes into their retinal artery. And I've had many of those patients.
Right. So amaurosis.
Yeah, and then sometimes it gets better, amaurosis fugax, where it's like a curtain going down on their vision and then it improves. Sometimes they lose their vision permanently, and that can be a really horrifying thing. But most of those patients, a lot of those patients at least, they're going to have carotid disease or atrial fibrillation or some underlying secondary mechanism usually.
Right. To cause that.
Can I ask you kind of a silly question, I guess?
No
So
question
we've
is
all
silly.
seen, thank you. So we've all seen pictures of the arteries with like the big ugly
Yellow.
plaque in there,
Yeah,
right?
yeah.
So now when you put a stent in, what happens to the plaque?
It gets pushed out to the side. And
Okay.
now the blood
and it's
flow.
trapped, like it's in
trapped.
prison, and it
Right.
can't like
It can't
hurt
break
you.
off, it can't
Okay.
go
And-
north to the brain.
And
Okay.
over a period of time, or within 30 days, usually the stent epithelializes. That means the lining grows so that it becomes part of the
Nice.
vessel wall.
Okay.
Yeah.
All right, that makes sense.
Yeah, what I think is really amazing too these days is what's done with aortic aneurysms. We should talk about that because,
Yeah.
years ago it was you had a big abdominal surgery,
Yes.
you'd have to go in. There's a lot of morbidity associated. Sometimes patients would not survive surgery or they'd have complications like renal failure. And I'm sure there's complications that can occur, of course, now too.
Sure.
But now with stenting, it's just an amazing in and out procedure for these
Yes.
patients.
So abdominal aneurysms can very well be treated with stenting. In men, the size is greater than 5.5 centimeters.
Okay.
If you see
Yeah.
that, then it's something. Start thinking about fixing it.
Mm.
Women, it's smaller
Because they're
more prone to rupture at a smaller size in comparison to men. So there's 5 centimeter that
Okay, that's good to know.
How come they're more prone to rupture? Is that just something that you
Well,
guys
the
know?
vessels are smaller at baseline,
Yeah,
right?
the artery is
So-
smaller at
Strong.
baseline,
Yeah.
so there's that comparison to men,
significant.
it's more significant. So,
Okay.
Okay.
so 5 centimeters is for women, or any rapidly progressing increase in size, although it has not reached 5 or 5.5, but every 6 months we are doing ultrasounds and saying, it's growing every time you do an ultrasound. It's probably a reason to fix them.
Another term I hear about is the leaky aneurysm. Can you talk about that?
Yeah, so before the leaky, before I can answer Chris' question first, that yes, the stents can be done, and the stents can be done minimally invasive. That means
Yeah.
they now can be done with
In
just
the office still?
no, it's not office. It's a hospital-based
Okay.
procedure, but it can be done with just needle punctures in the groin, and you don't need
Okay.
like big incisions also.
Okay.
So it's kind of a cosmetic procedure.
Nice.
But leaky aneurysms is kind of something that you need to get fixed
Okay.
right away. That means the aneurysm is prone to rupture or will
Yeah.
rupture soon. It has not ruptured. It will rupture soon. So those those findings are kind of
Scary.
red flags. Yes.
The patient who has a leak in their aneurysm, what kind of symptoms would they have, if any?
So if it's an aneurysm which has never been fixed, and they say it's leaking, then they will have abdominal pain, back pain, and if they know that they have an aneurysm in the belly and they're having severe back pain or abdominal pain, they should not ignore the symptom. They should go to the hospital right away.
Right.
Yeah, they can if it frankly ruptures, they can be blood pressure can drop, they can collapse, but the pain is the one that brings the attention.
I'm just thinking, back pain or whatever. Like back pain, you're thinking of so many other things rather than a aneurysm. It's probably why there's probably a lot of incidental findings of aneurysms, right?
But it'd be different than typical back pain. It would be like non-mechanical, meaning like, with regular back pain, you pull a muscle, you bend over, it hurts. It's not going to be like that.
No, it's going to be
So it
severe
feels
pain
different.
that you're
Good to
taking
know.
Tylenol, you're taking your regular stuff, and it's
Okay.
not. It's going to be
Not
pain that wakes you up from your sleep.
Okay.
It's
Right.
going to be
All right.
severe pain.
Nice.
Kidney stone level pain,
Yeah.
Yeah.
perhaps.
Yeah, it's going to be severe pain. You should not ignore
Okay.
that symptom, especially knowing if you have an aneurysm.
Yeah,
Yeah.
good. So the other thing I wanted to ask you about, we had talked about venous insufficiency and the leg swelling and everything. So we're having a heat wave right now.
Right. It was warm out
Like,
Tomorrow it's going to be more.
you know,
there.
yeah, it's going to be bad
It'll be
tomorrow.
100 tomorrow?
Yeah, so we're taping this on June 23rd. So we're looking at tomorrow's temps of what, like 95 or something like that.
It
It's
was
a little
hot today,
crazy.
that's for sure.
Yeah. So now during like the summer and these like really hot months, are you typically seeing worsening with this, or is it not so much relatable to the?
Patients do say that during summer months and their legs are more swollen.
Yeah.
And is it weather, or is it because they're not able to wear compression socks in this weather?
Oh, good point.
So, but they do if you ask, they're like summer months are pretty hard. Our legs are swollen, and they're more active. They're more on their feet during summer months
Yes.
than winter months.
Yeah.
And they cannot wear, definitely in this heat, it's difficult to put those knee-high, thigh-high
Ooh.
compression socks.
Sure is.
So yes, they do.
Can I just ask you a quick aside about compression socks? So if I order some off of Amazon, are they different from what you give me in the office? Like, are they all work pretty much the
They're all
same?
as far as you just make sure the pressure on them is what your physician recommended. So
And you're putting them on when you're like,
daytime hours, your
Daytime
active
hours.
hours. Like if you're working at night, if you have a night shift and you're on working at nighttime, then you put those. So don't go to bed with compression socks.
and like first thing, like so you're not
Yeah, when
having
you
like
first
a lot
get
of
up.
swelling. You just go whoop,
Yeah.
Put 'em on.
you're all set.
Yep.
Easier to put them on then.
Yeah. All right. Cool.
Fascinating stuff.
Yes, and we could have done a deep dive down the rabbit hole into like any one of these topics
Yeah,
that.
there's a lot that you can get into. But this was a nice overview of vascular disease, I think. And
Absolutely.
we did hear how it differs in women, too, a little bit.
Right,
too,
right.
which is
So
nice.
I always say that women somehow presents like a little more advanced stage
Yeah.
disease, and I would definitely say to all my women friends, family members, like, do not ignore your symptoms. It's not your multitasking capabilities or anything. It isn't.
Yeah.
It's not a. I mean, nobody's questioning that. But if you have symptoms,
Right.
talk to your doctor. Something,
That's a great
checked.
message.
get checked.
Can you think of any, one particular case that really sticks out in your mind where it really made a difference, where someone maybe brought this forward in an earlier stage or something of that?
Right.
matter?
So I actually recently had a very young female patient who came to me with abnormal carotid ultrasound. And when I looked at the ultrasound, I was like, wow, that's pretty tight plaque or pretty tight narrowing in that blood
Sure.
vessel. And in my mind, I have not seen the patient. I've not done it, just an ultrasound. And I'm like, oh, must be having various risk factors. You must be smoking, must have high blood pressure, diabetes, or bad family history, or something in my mind. And when I talk to the patient, I see her, and absolutely no, never been a smoker.
Wow.
Perfect picture of healthy diet and
Really?
exercise that you can think about. Never had to take any kind of medications in her life.
Wow.
Just I was like, oh, can I
anomaly, yeah.
I take your diet and health and exercise and things like that? But she's like, perfect. All the supplements and watches what she eats. And sure, I'm like, okay, I do not know why you have this. Pretty significant. So we get a CAT scan just to confirm that what we are seeing is true. And she does have a pretty tight narrowing in her carotid artery, and it is at a location which does not sounds like any other less found non-atherosclerotic reason to have a carotid disease. Carotid bulb, which is where the narrowing in the carotid arteries happen with a patient who has plaque. So, okay, I said, okay, you have it. I do not know why you have it, but it's pretty tight and we should treat it because your risk of stroke or a stroke like event increases. So, when I did the surgery, what I found was a typical atherosclerotic plaque, fibrofatty, just fatty plaque. It was not something suspicious. So I was like, I do not know why you have it. I do not know if your genetics, there's some genetic testing we can
Yeah.
do, or her lipid panel completely pristine normal. But I was like, you need to start aspirin and high dose statins.
Yeah.
I do not know, but it was
Yeah. And did she have vascular disease elsewhere?
no, nothing.
That's
I was
This
gonna
was
ask
a
that
on one finding of the only thing that I could think about is that she did say that she started having menopausal symptoms, like pretty early in
Yeah.
life,
Interesting.
and she could not tolerate hormone replacement therapy.
Right,
But she was having all these symptoms of mood swings and irregular periods and hot flashes.
Right.
But she could not tolerate. But she's on the younger side, so that
Right.
that
Kinda
young
threw ya.
population it becomes a little why you have it, right? Does
Right. Yeah.
that mean you have somewhere else? So yes,
So, just for the reason that she had it, should her siblings get checked too? Is that something that you would be like, I wonder what's going on? Or do you think there was no familial?
I don't think so of familial, but I think that this hormone replacement maybe, and then some form of dyslipidemia or that she has that I do not know.
It's a good thing she had a healthy lifestyle. She could have
Very
been in real
healthy
trouble
lifestyle. Oh, very healthy.
much
lifestyle.
earlier.
Yeah,
Nice.
this was
That's
the
an
most
interesting
recent.
case. I had a really interesting one recently. It was an older woman who her only complaint was she didn't feel well and her blood pressures were different on both arms. She may have actually ended up seeing you. She saw
Oh, okay.
someone in your group.
Okay.
And then I did a CTA and basically she had a 90% stenosis of her subclavian on the
Oh, wow.
right side.
Oh wow.
So, and her blood pressure differences were remarkable, like 40-point difference.
Right.
Yeah.
Right.
Which was interesting, you don't
Yeah, and
see that.
usually some of these patients, if you are not careful and they just keep taking one arm,
Right.
they say, "Oh, our blood pressures are normal."
Yeah.
Right. Exactly.
But it's not normal. It's the side which is the higher blood pressure is your normal blood pressure.
Right. Exactly.
So their blood pressure, they may get undiagnosed and may never get treated. They're like, "Oh, it's always low.
Right.
It's never high."
Sure. Yeah. Interesting. There's a lot of interesting stuff going on
Yes,
out there.
yes.
But, this was great. I think hopefully the audience enjoyed this. I'm sure they did. And they learned a lot about, what they need to do to hopefully prevent vascular disease.
Yes.
Address it early, and particularly with women, to think about this earlier and not just blow off those symptoms.
Correct. Absolutely.
And that's just so critical. So I want to thank you so much for coming on to the show. It was great.
Thank you.
Yes. Did you have any other questions?
I did not.
All right.
Yes. Thank
Well,
you so much.
Yeah,
yes,
we could have
it's
gone
a
on
great
quite
opportunity.
No,
Yes.
it was wonderful. So, once again, thank you so much, and thank you for everyone out there for listening to our show. And if you'd like to become a sponsor, please contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music. Primacare, your trusted medical providers in southeastern New England. BioSkills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. And if you want to get in touch with Dr. Dosi, her number, and we'll post it, is 508-673-4329. And she's available to help out with any of your vascular concerns that you may have. So if you have a concern, give a call. You can be referred by your primary care doctor, of course, also. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And thanks again, everyone, for watching our show.